Antibiogram and Dr. Deepashree, uh, are you ready?
Yes, sir. Yeah.
You are going to present. I will close it, or you will present from here.
No, sir. I'll share my screen, sir.
Okay, so I am closing mine then.
Okay. So, sir has explained everything about antibiogram now. All the basics are covered, and also we know what are the various types of antibiogram. So, this is the most important component of antibiogram, that is routine antibiogram. This is being discussed. The principles what is discussed in routine antibiogram holds good for all the other antibiograms also. Okay. So, this next what we are going to discuss, if you all remember when Pallab sir explained the disadvantages of antibiogram, that you cannot give it catering the needs of so many sectors. So for all of those, the answer is you can develop enhanced antibiogram, which requires more planning, and it should be planned at the beginning because the data has to be collected. So we will discuss all that. So the question, I'm not going into the polling because of the time limit. We'll discuss the questions. The following filters are applied in enhanced antibiogram but not in routine antibiogram, except which one? Okay, so yeah, one second. Yeah, so it is the first isolate filter. Now sir has explained what are the various level of filters you can apply to generate antibiogram. So in your routine antibiogram there are two filters which you will apply, that is first isolate filter and organism specific filter. Rest all filters when you apply, that is location specific filter. Specimen filter is also called a syndromic. When you collect the data applying the specimen filter, it is called as a syndromic antibiogram. And there is healthcare associated and community associated filter also. So the stratification can be done by applying various filters. So various filter is date filter, zone filter, that is now there is a study going on also, that is multicentric study is going on to collect the pan India filter. So you can apply pan India filter, or you can analyze your antibiogram in the South India, North, West, or East India. So likewise zonal filter can be applied. Facility specific filter, that is all the hospitals together and public private separately. Sub facility specific, that is center specific or standalone labs, the filter can be applied. And also if you start collecting the data regarding the date of admission of the patient, you can also collect the data on whether it is a hospital acquired infection antibiogram or it is community associated. Location filter can be applied. Broad specialty filter, that is depending upon the area of the patient you enter, that is medicine, surgery, pediatrics. So broad specialty specific filter also can be applied. Subspecialty filter can be applied. Age filter can be applied. Sex filter, that is in all gender, male and female separately. Specimen filter, so specimen filter will give you syndromic antibiogram. These two 11 and 12 together will give you syndrome specific antibiogram. Organism filter we apply. Phenotype filter, that is all the phenotype versus specific MDRO phenotypes. Episode filter, that is 7 days, 30 days, that is you select the first isolate based on what criteria. Isolate selection filter, that is you collect all isolate. First isolate, most sensitive isolate, weighted average, and most resistant isolate. Then there is also minimum. So this last one, 17th one, is not the filter, but it is a criteria, that is minimum number of isolate we are going to choose. Mostly we choose 30 isolate. So all this is included, all these filters can be applied to generate a better antibiogram catering the needs of the clinician. In all these, for everything, the common factor is you do not include outbreak isolate or surveillance sample isolate for collecting the data. You only you exclude the outbreak isolates. Okay, so your from 2, that is zone filter, till 12. Specimen subtype filter is exclusively for enhanced antibiogram. Okay, all these filters can be applied, especially the most important one is 11th and 12th filter will give you specimen specific antibiogram, that is syndromic approach antibiogram, which is very very helpful for clinician to choose the empiric antimicrobial therapy. So there is another. Yes. Okay. So there is another type of antibiogram that can be generated is based on the prevalence of MDRO. You can generate, that is, in your antibiogram report you can include the details of MDR isolate. For this you should remember one important point is you can only report this MDROs if you're testing that particular antibiotic routinely. Say suppose you're doing colistin MBD but you're not doing for all isolate. If you're doing only for resistant isolate as a second set of drug, you, because you're not doing for all routine isolate, you cannot include it in your antibiogram. If it is whatever is routinely tested can be included. And when you're taking note of all this in your uh, whenever you're collecting data on day to day basis, when you're generating the antibiogram, in the footnote you can, or you can make a separate table regarding what is the status of VRE, what is the status of MRSA, what is the status of MDR, XDR, PDR. And in Klebsiella organism specific MDR, XDR, PDR rate can be given to the clinician, can be shared with the clinician. Again, the clinician will have a better view on choosing the appropriate empirical therapy. Even carbapenem resistant organisms can also be included. So what is the additional analysis of MDR? So you can see this table here. This is a type of antibiogram which is generated for Klebsiella pneumoniae. You can see it is Klebsiella pneumoniae antibiogram with data segregated based on resistance mechanism. So the first one they have included what? Just a second. Okay, the first one they have included all Klebsiella isolates. You can see that is 1163, and they have also, because they have documented ESBL, KPC, and other drug resistance mechanism, they have segregated the number. But again, you can ask, are we are not doing that routinely? If you're not doing it routinely, you need not include, because in this document itself, it is told that detection of enzyme is no longer done on a daily basis. This antibiogram cannot be constructed in most of the facility except for exclusive research centers. Okay, so Klebsiella pneumoniae extended spectrum cephalosporin resistant is 233, KPC 361, and does not have both ESBL and KPC is 569. Like this, you can give split up of data even based on the resistant mechanism. So this is another table which is very very important. This is combination agents antibiogram. So whenever we go to the bedside, we see that especially when they choose empirical therapy in systemic infection in ICU setting, they give double gram negative coverage. They tend to combine amikacin with cefoperazone sulbactam or amikacin with piperacillin tazobactam. There are few examples in this table: ceftazidime ciprofloxacin, imipenem ciprofloxacin, ceftazidime tobramycin, as such. So these examples are there, and you can see the table here, that is the last four columns. You can see in an antibiogram you can also generate the antibiogram based on combination agent. How do we do this? In this example, so it's first we'll take ceftazidime or ciprofloxacin. You can see the word, it is and bar or. Okay, it is and bar or means, what is the meaning of that is, if ceftazidime is sensitive, ciprofloxacin is resistant, you consider for this. If ceftazidime is resistant, ciprofloxacin is sensitive, again you consider in this, or both are sensitive, you consider in this column. There are three scenarios. It should be either one sensitive or both sensitive, you consider under this. That is why you can see ceftazidime ciprofloxacin combination agent has more number than individual agents. So one more thing you should keep it in mind is, just because you are giving an antibiogram like this, it does not mean that you are confident on whether it is synergistic or antagonistic. That we are not committing. only to help the clinician understand what is the impact if they give these two drugs together. If they are choosing a combination therapy, will this be helpful, or what is a percentage compared to the individual susceptibility range can be inferred from this. Okay, again I'm repeating, it does not mean that we are not committing that whether they both are synergistic, or giving the combination therapy is better than monotherapy. We are not committing, because they are using, we are combining the susceptibility percentage in the formula of and or. So as I told you, in ceftazidime and ciprofloxacin percentage has, there are isolate which is ceftazidime sensitive cipro resistant, or ceftazidime resistant cipro sensitive. Any one agent is sensitive also, we are going to combine and give this percentage. This will help the clinician whenever they are choosing double gram negative coverage for their empirical treatment.
Deepashree, I want to interfere.
Yes,
Uh,
sir.
there are some indications of double gram negative coverage. Like, for example, oncology patient having a past history of MDR or infection, or having a rectal isolate of MDR. So those kind of indications are extremely sick oncology patient. So extremely sick oncology patient, or maybe the critically ill patient in ICU. So there are some fixed set of indications of double gram negative coverage, and the combination of combination agent antibiogram is a boon to the clinician. Our clinician, they choose blindly which two antibiotic you take. You take amikacin for ticacycline, meropenem plus colicin, based upon what policy you are telling. हवा में randomly they select. So combination as an antibiogram will objectively tell them that among the various combination, what combination is going to work. So this is going to be a big difference to the clinician when they choose the double gram negative coverage. Please continue, Deepas.
Yes, sir. Yeah. So this is about combination agents, antibiogram. Next is calculating the susceptibility percentage for select organism group. So again, this is very, very important whenever whenever only gram staining report, example in blood culture, when a blood culture bottle flags, we know whether it is GNB or GPC. At that point of time where we only know gram stain result, we do not know the ID or AST of that particular isolate, this antibiogram will be very, very helpful. Means for every drug, say, so say example, in this example you can see here, you are telling the clinician, if it is a GNB, what is the effectiveness, or what is the percentage of isolates if GNB are susceptible to piperacillin tazobactam. So it is based on the gram stain and on the drug. It is not that particular organism particular antibiotic. We are just telling, if it is GNB, what is the percentage of the organisms in gram negative are susceptible to piperacillin tazobactam. So this is at the very initial stage, you can start guiding the clinicians regarding choosing the empirical antimicrobial therapy. So in this example, so how do we go about calculating the susceptibility percentage of piperacillin to GNB? Very clearly explained here. So you take the isolates, the number of isolates of all GNB, then you'll get total number of isolates tested. Then you also calculate addition of all the isolates which are susceptible, number of isolates susceptible to piperacillin tazobactam. You calculate the percentage using total number of isolates susceptible to piperacillin tazobactam divided by total number of isolates tested. So this is a formula you use, and you can even calculate this and keep for all the at least most commonly chosen empirical antimicrobial drug for gram negative and gram positive, and you can guide the clinician. Very, very interesting type of antibiogram, where you're giving an antibiogram even at the gram stain level. So this is the picture. So you can see here all GNB for blood culture. So once you I have we have seen the example for piperacillin tazobactam in GNBs. Likewise, you calculate for all the primary agents which are chosen for treatment in your healthcare setting, and you can calculate like this. It will give an overall picture for the clinician regarding what could be the agent chosen once we inform the gram stain report to them, because in blood culture the communication happens at all level. We are going to tell when the bottle is flagged, then we are going to inform the gram stain report, we are going to tell the ID and direct susceptibility report, then we are going to tell the confirmed susceptibility and definitive ID. So at all levels we can help the clinician to choose the correct antibiotic. Okay, so this is the second question. Only two questions are there in enhanced antibiogram. So the following are the indications to use all isolate data for antibiogram except. So there are very specific indications where you use all isolate data, otherwise it is only the first isolate, which is the condition you use all isolate. So this has been already elaborated. So to identify emerging resistance, we use all isolate. For infection prevention control purpose, yes, we use all isolate. For detecting rare phenotypic, we use, and monitoring the development of resistant isolates in a patient over the time, that is vancomycin intermediate susceptible staph aureus. So in all these conditions we use. For empirical therapy, if you use all isolate data, the antibiogram will get biased and shift towards more resistant, it will show a false data. That is why for empirical therapy you use only the first isolate filter. Okay, so this is a list to identify the emerging resistance. Infection prevention, quality assurance, detecting rare phenotypes like colistin resistant Klebsiella, assessing resistance profile among all isolates encountered in a facility, and monitoring the development of resistant isolates in a patient over a period of time. So all these are the indication for using all isolate data. So this is about enhanced antibiogram. Sir, I have finished. Sir,
Obviously.
yeah.
So other type of antibiogram is going to be presented by Dr. Ketan, following which use of antibiogram I will brief, and then Ketan will be discussing on MIC guiding tables. So all these three will happen together so that we will save time. So the Deepashree, you can come out of the slide. Thank you.